Our next speaker is Dr. Neil Binkley. He's the co-director of the University of Wisconsin Osteoporosis Clinical Center and Research Program. He's professor of medicine, the University of Wisconsin School of Medicine and the School of Public Health in Madison. He received his medical degree at Madison and University of Wisconsin. He was at the Marshfield Clinic. He was a fellow up in Madison in geriatrics. He was a postdoc fellow at the NIH. He's associate editor of the Journal of Clinical Densitometry, and he's going to talk today about sarcopenia, fat, and fracture risk.
And, you know, it's probably not smart to start a talk by saying, I'm not going to tell you anything that you're going to implement today. But I think that's true. But I think and hope that this concept is where the, quote, osteoporotic field is going. And I'm also going to share with you a syndrome that you've never heard of before because it doesn't yet exist. And we're going to be talking about a concept that our group has submitted an editorial to speak to dysmobility syndrome. And just sort of keep that thought in mind as we go forward. I have nothing to disclose in regards to this because sarcopenia and dysmobility has no drugs associated with it yet. A lot of this is going to be my opinion. And so when you see orange font on the slide, that's your clue that this is my opinion. So let's step back a little bit and say, why are you treating osteoporosis? What we're calling osteoporosis. And the obvious answer is we're doing that to prevent fractures. So the real disease here is fracture. That's what we want to prevent. Obviously, low bone density is asymptomatic. It's very analogous to cholesterol. This figure, I think, is a really telling reason behind why we need to be doing a good job at preventing fractures. It's a wonderful review of aging that was published in Lancet a few years ago now. And what you see is that practically linear increase from 1840 until 2000 in life expectancy. And the author had a real telling commentary that kids born in this century should expect to live to be 100. Expect to live to be 100. And that means that their bones need to get them there. And so I think our job really is to optimize musculoskeletal health to allow us to have reasonable quality of life. If we're going to live to be 100, that means we need to prevent falls and we need to prevent fractures. Now, let's think about what we've done. Historically, we as osteoporosis docs have had our blinders on and we've just focused on the bone. And now we're tending to focus more on the patient and on their risk for fracture, and I think that's certainly appropriate. This is an obvious reason why focusing just on the bone doesn't work. So these are prospective data from the Rotterdam study. And what they show, and this is femoral neck BMD, femoral neck T-score. What they show in the purple bars here is that less than half of the fragility fractures occur in patients with T-score osteoporosis. I don't think that's surprising. There could be folks with borderline BMD or osteopenia who are going to fracture. Certainly you don't necessarily have to have elevated lipids to have a heart attack. Why would you have to have low bone density to have a bone attack? So it's often focused on the osteopenia group, but look at this. There's a bunch of folks who are having osteoporotic fractures with normal BMD. Maybe it's not the bone that's the problem. Maybe it's the patient that's the problem. So I think that fracture risk calculators, and Mike has discussed FRAX, I think these are clearly a step in the right direction. They're making us think about fracture risk. I do want to highlight the Garvin calculator. Mike listed nicely, I think, the limitations of FRAX. In my practice,